Hello everyone, I'm Dr. Niharika Jha, and via this YouTube channel of Dermacoaching, I try to take up certain interesting cases in dermatology which I encounter in my daily OPD. Today's case discussion is based on angina bullosa hemorrhagica, and I really hope that you find this case discussion to be of some help. Before going on to the topic proper, I would like to inform you that we take detailed lectures on important topics in dermatology, and you can visit us at www.dermacoaching.org to purchase the same, or else you can also write an email to us at dermniharikajha, that is dermniharikajha at gmail.com. Now let us come to the topic proper. How did I diagnose this particular patient to have angina bullosa hemorrhagica? So a 40-year-old male presented to me in the OPD and has made complaint for painless blood-filled lesions in the oral cavity, which were present only for the past 2 weeks. So you can see that there are blood-filled lesions in the oral cavity. They were painless in nature and they were present only for the past 2 weeks. It was not associated with any burning sensation. The patient complained of only slight difficulty in eating food. There was no prior drug history. The patient was not on any aspirin or any other blood thinners. No history of trauma, at least that he could have recalled, which could have resulted in this bulla formation. He did not undergo any dental procedures, and there is no known history of any bleeding disorders in this patient. So what did I find on examination? On examination, I found partially resolved, flaccid, hemorrhagic bullae on the palate. Few small blood-filled vesicles were also present here and there on the palate, but one big hemorrhagic bulla was present, and which was almost partially resolved in this patient. No body lesions were present of any sorts, and I tried performing Nikolsky in this patient with the help of an earbud, and the Nikolsky was negative. So after checking the patient thoroughly and taking a detailed history, these were my differential diagnosis. Bullous pemphigoid, pemphigus vulgaris, fish drug eruption, bullous oral lichen planus, post-traumatic bullae, and angina bullosa hemorrhagica. So let us try to discuss each of the differential diagnosis. So bullous pemphigoid, ideally patients of bullous pemphigoid do not have oral lesions, but 40% of the patients of bullous pemphigoid can still have oral lesions. But for a patient to have only oral lesions and no body lesions is kind of difficult in patient of bullous pemphigoid. Mind you, I'm talking about bullous pemphigoid right now, not mucous membranous pemphigoid. So this patient did not have any body lesions and only lesions in the oral cavity were present. The second diagnosis was mucous membranous pemphigoid, which can be considered to be a variant of bullous pemphigoid. In such patients, the mucosal lesions they resolve, leaving behind scarring. Now, the lesions were present for the past 2 weeks and they had almost partially resolved. Till now, no scarring was seen in the oral cavity, and other mucosal areas were not involved. So, it was difficult to comment if this was mucous membranous pemphigoid. Pemphigus vulgaris. Now, many patients of pemphigus vulgaris can initially present with oral lesions alone, but mind you, the lesions of pemphigus vulgaris, the oral lesions, they are very painful in nature. The patient is not able to eat, the patient is not able to drink. It is very traumatic for the patient. So, in this patient, the lesions were totally asymptomatic. It was not at all painful, not at all associated with any kind of burning sensation. Also, no body lesions were present. When I tried performing Nikolsky in this patient, it was negative. So let us move to the third diagnosis, fixed drug eruption. But the drug history was negative. The patient was not on any drugs prior to the eruption of these bullae. Bullous oral lichen planus. Now, bullous oral lichen planus, it is a rare form of oral lichen planus. Many patients of oral lichen planus can have burning sensation, but this was absent in this patient. Also, when I tried examining the other body part, no lesions were present, which was suggestive of lichen planus. What about the next differential diagnosis? Post-traumatic bullying, the patient could not recall any major trauma that he could have suffered near the oral cavity, um, which could have resulted in the formation of this bulla. And then comes the diagnosis of exclusion, which is the angina bullosa hemorrhagica, in which very minor trauma, like even sometimes brushing the teeth, or might be because of the cheek bite, and it might be drinking hot beverages, such kind of mucosal insults can result in angina bullosa hemorrhagica. So it becomes a diagnosis of exclusion. To come to a proper diagnosis with the help of ENT surgeon, took samples for histopathology as well as immunofluorescence. So what did the histopathologist see in this slide? So the histopathology report read, the biopsy shows some epidermal blistering dermatitis. So it was a subepidermal bulla. And what was the bulla containing? It was containing abundant fibrin along with eosinophils and neutrophils. Okay. And in the dermis, there were superficial perivascular fixed infiltrative lymphocytes and eosinophils, and occasional neutrophils were also present. Okay. Now, because of the presence of the subepidermal bulla and presence of the fibrin and eosinophils in the bulla cavity, one might think that this is a bullous pemphigoid. And this needs to be confirmed with the help of DIF, that is direct immunofluorescence. Okay, so but there was some problem with the immunofluorescence. What was the problem with immunofluorescence? It was negative. Now we know if you are suspecting a patient of bullous pemphigoid, IgG deposition, IgM, or might be C3 deposition should be seen at the dermoepidermal junction in the immunofluorescence. But even after checking it twice, no immunofluorescence was positive for any of the antibodies. It was totally negative. Now that brings us to square one, because that is the confirmatory test for bullous pemphigoid. If it is not positive, then what else can this subepidermal bulla be? Now let us go back to our differential diagnosis. Yeah, the differential diagnosis bullous pemphigoid, it is doubtful because immunofluorescence is negative. So it kinds of rules bullous pemphigoid. Pemphigus vulgaris does not have a subepidermal bulla. Again, rules out the pemphigus vulgaris. It does have suprabasal. The cantholisis is seen, but no such things are seen in this particular patient. Then no features suggestive of fixed drug eruption or oral lichen planus was seen. And so again leaves us with this particular diagnosis of exclusion, that is angina bullosa hemorrhagica. Now, why this is angina bullosa hemorrhagica is, first of all, the histopathology features are not matching with any of these. Okay, immunofluorescence is negative, so again bullous pemphigoid is completely ruled out. Now that makes it to angina bullosa hemorrhagica. In this, again, subepidermal bulla can be seen. Although many times the inflammatory infiltrate is not much, but but because this was an old bulla, slightly dissolving, that is why we might be seeing so much of inflammatory infiltrate, and also these patients obviously have negative immunofluorescence. So that is why we decided to consider this case to be a case of angina bullosa hemorrhagica. What did we do for this patient? We started the patient on symptomatic treatment, and the patient responded very well. Most of the lesions got self-resolved. Until now, the patient did not have any recurrence. This again proves that this is not bullous pemphigoid. Without giving any oral steroids, the patient simply responded to some lidocaine gel, Zyte gel, chlorhexidine mouthwash without giving any oral steroids. Until now, there is no recurrence. So this is again a confirmatory proof that this is not bullous pemphigoid. This is a case of angina bullosa hemorrhagica. Now let us discuss what is angina bullosa hemorrhagica. So this is basically subepithelial oral mucosal blisters, and these blisters, they are filled with blood. But the catch is that it is not associated with any systemic disorder or any kind of bleeding disorders or hemostatic disorders. This is a very rare condition, not very commonly seen, and elderly patients are usually affected by such kind of problem. Most of the lesions, they resolve spontaneously and they do not leave behind any scarring. So after resolution, plain pallid was left behind. No scarring was seen in this patient. The exact cause of this particular problem is not known. It is idiopathic in nature. The onset is also sudden. So, what could result in angina bullosa hemorrhagica? Minor mucosal insults, as I've already discussed, it can be eating or drinking hot beverages because of any dental procedures. Minor trauma such as brushing or even shouting can act as provoking factors. Even those patients who are on long-term use of steroid inhalers can also be prone to developing angina bullosa hemorrhagica. If we talk about the histopathological features, so there will be a subepithelial separation, which we saw. Superficially located vesicles can have erythrocytes and fibrin, which we saw, and the inflammatory cell infiltrate primarily consists of the lymphocytes. So, the features of this particular patient were very similar to the typical features of ABS, angina bullosa hemorrhagica, presence of the fibrin and the erythrocytes in the superficially located vesicles, while lymphocytes can also be seen. But what is the catch? These features, because they are very similar to that of bullous pemphigoid also. But immunofluorescence is negative. There is no evidence of IgG, IgM, IgA, or C3 antibodies within the basement membrane zone. In our patient also, no immunofluorescence was detected on direct immunofluorescence at the basement membrane zone, even after checking the immunofluorescence twice. What is the treatment? Symptomatic treatment can be given. It is a self-resolving condition. So this patient also resolved after giving slight symptomatic treatment. So I hope you found today's case interesting and it was of some help to you. I will just give a brief conclusion of this particular case. So angina bullosa hemorrhagica, first of all, it is a rare disorder. It is a diagnosis of exclusion. It should not be the first diagnosis on the list of DDs. Secondly, if you look at the lesion, they will be having asymptomatic bullous lesions which are hemorrhagic in nature, and they might even self-resolve even without giving any kind of treatment.